Top Med Talk.
All right, and welcome back to Top Med Talk here at Anesthesiology 2018. I'm Desiree Chappell, host of our program, and I'm joined this morning by Monty Mythen, Editor-in-Chief of Top Med Talk. Good morning, Monty.
Hi, Desiree. Good to be back.
We are rolling on the Smith's Medical booth at booth 1519, Top Med Talk. We have a desk here, and we've been rolling all morning from it. It's going really well. What do you think so far?
It's fantastic. It's really, really great. We're back in the... what's the trade exhibition called this year? The
Connection Center.
Connection Center. We're in the Connection Center here. You know, it's buzzing. It's buzzing. The crowds are just starting to come in for their lunch break. And we've got a beautiful setup here. It's a beautiful setting. Lots of places for people to come sit down and engage with Top Med Talk.
Yeah, that's right. So if you're listening, if you're in the exhibition hall, the Connection Center, and want to come over and have lunch here, you get your lunch and you can sit down and talk with us and engage. That would be great. So here this weekend, we are going to be at the Smith's Medical booth all weekend talking about enhanced recovery. That's the theme for our weekend.
Absolutely.
Right? Yep. And we said earlier, the mission of Anesthesiology 2018 and the meetings here is really bringing and coming together of people, colleagues and anesthesiologists and providers from around the world to improve care through education and networking. So Top Med Talk, that's what we do, right?
It is. Top Med Talk, as we keep reminding people, is the broadcasting arm of evidence-based perioperative medicine. Evidence-based perioperative medicine, 20 years old. Myself and Sol Aronson, who we'll reintroduce in a moment, we're at our 20th anniversary meeting at Dingle on the west coast of Ireland recently, but EdPom now has a global presence, EdPom International, with meetings running in Hong Kong, have run in Australia. Sol Aronson has led the introduction of EdPom USA that's been running successfully, which we can pick on a little bit later. So great that this is our broadcasting arm, bringing a presence such that we're reaching 90 countries around the world.
That's right. And also reaching everyone here at this wonderful meeting this weekend. So today, like I said, we're going to be talking, or this whole weekend really, about enhanced recovery and how we improve care through this quality improvement program for the perioperative surgical patient. So today we're joined by two very special guests. First of all, we have Sol Aronson. Sol, thank you for joining us.
Pleasure to be here.
Yes. So, Sol, you're from Duke.
I am.
Yes. And what is your role there at Duke for all those people out there who do not know you, Sol?
Oh, giving away all my secrets, Desiree. I'm the Executive Vice Chair of the Department of Anesthesia, and I also sit on the Board of Directors for the Practice Plan and the Accountable Care Organization.
That's right. Very good. Okay. And our other special guest, we have Dr. Vijaya Gottumukkala. He is from MD Anderson, Professor of Anesthesia and the Deputy Chair there. And Vijay, you were telling me some other things that you're involved with there at MD Anderson. What are those?
Yeah, so I wear multiple hats. One of my other role is I'm the Program Director for Cancer Anesthesia Fellowship. This was the inaugural fellowship we started about 2011, first time in the country. And I'm also the Director for PACE, which is Program for Advancement of Perioperative Cancer Care.
Very good, very good. So the topic today, in which I had talked to you before you came on here, we were going to talk about team-based approach to care, pathways, protocols, patient empowerment, and how can enhanced recovery improve by utilizing those. So that's kind of what I want to start out focusing on. I know that MD Anderson, you guys have been utilizing enhanced recovery there in your facility for cancer patients for a while now. Can you tell me a little bit about the program there?
Yeah, so we started with the enhanced recovery journey for our patients about 5 years ago. Initially started with liver surgery because of the close relationship I had with one of our liver surgeons. Now we expanded to about 13 service lines within Division of Surgery, but also 3 programs outside Division of Surgery. So we are adopting similar multidisciplinary, patient-centric, recovery-focused care to patients undergoing stem cell transplantation, patients with medical oncology who get admitted to the oncology floor for readmissions after mainly liquid tumors, and also enhanced recovery in emergency department. So it's really become a fabric of our care, and it's our goal to make patient-centric, recovery-focused, outcome-based, efficiency-driven care as part of our fabric of patient care at MD Anderson.
Vijay, we were lucky enough this morning to interview Professor Henrik Kellett, and he emphasised that when he first came up with the enhanced recovery principles as a surgeon, he said not only do you have to reorganise the teams, but the pathways and the protocols are procedure-specific, not surgeon-specific. Now, that was quite a paradigm shift in the UK. I'm guessing it was a huge paradigm shift in the USA. How did that go down at your shop?
That's so true. When we first started, there was obviously not that much interest, enthusiasm, a lot of skepticism, as all of us have seen in our own journeys. But the skepticism was seen more amongst anesthesia colleagues because they did not believe what we do in the short term could make such impactful change to patient care. But when the surgeons have seen how well the patients do, when they've adopted or bought into the concept, and they've started asking our anesthesia colleagues, why couldn't all of us do this practice? Then it's become just widely accepted. And we've had a mission creep. In fact, we've had difficulty keeping up with the interest and how do we create sustainable programs in the long term. It's not just the initial spike in interest that we want to adopt enhanced recovery for colorectal or gastric or HIPEC principles, but how do we make sure that these programs are sustainable in the long term?
And so was that the same? Because I used to work at Duke. I keep going on about
many
that.
moons
ago. And the idea that you would have a procedure-specific pathway rather than every different surgeon having a different recipe to make the same cake, which I just couldn't keep track of on the SICU. Patient A, this is the right drug. Patient B, exactly the same challenge. This is the right drug. Has that stopped?
I'd love to say yes, but that would be disingenuous. It is a steep hurdle. The slope is very, very steep to get that kind of buy-in, but I think it's a steady gain. We see it not just in the enhanced recovery protocolization, if you will, but in the entire paradigm of perioperative care. And we're just, I think it's fair to say, scratching that surface in the States. You've had decades to learn from experience, some of them based on easy lessons, some based on, I would portend to say, difficult lessons. We're just at the beginning of that journey right now in the States.
And the anesthesia providers, are they... Because we were all over the place as well, weren't we, from believing that we each knew the right way to give an anesthetic.
There's no question. I don't think the adaptability, or on the other end of the, I guess, continuum, arrogance of any one kind of professional is specific. It's agnostic. Arrogance is agnostic. And lack of adaptability is agnostic. And we all suffer from that same flaw in character. And I think we're having to just continue to chisel away and be tenacious. But we are making progress, though albeit slow.
Yeah. Vijay, did you?
So with pathways and protocols, at least in the U.S., the skepticism and the hesitance has always been that you're taking away the independence from the practitioner and you're taking away their ability to practice their art, so to speak. But now what we're learning, at least the MD Anderson experience, has been if all of us do things a similar way, which are procedure and patient specific, and when a patient does not meet into that goals of recovery, we are identifying why the patient is falling off early, and we are able to intervene much more early in a much more effective way to improve the patient outcomes. So that was one. The second thing what we've realized is even pathways and protocols should be risk stratified. This is particularly all the more important in the post-operative phase. For the intraoperative phase, there are no pathways. For us, it's goals of care. Oh. But all the pathways and protocols come into play in the post-operative phase, at least at MD Anderson, mostly driven by surgical units and surgical services. So what we were able to do to be effective, get the buy-in from the surgeons, is to risk stratify these pathways based on a particular risk. As an example, for pancreas surgery for Whipple's, the biggest risk is pancreatic leaks. So the different pathways the patients are put on in the postoperative phase in the context of enhanced recovery is based on their risk for pancreatic leaks. How soon can we get these patients fed safely without necessarily impacting their care?
And within that, sorry, Desiree, I sort of see a degree of adaptation of pathways to patient risk as well. In other words, a much frailer, much higher ASA score polypharmacy patient needs some degree of modification.
Absolutely.
Well. Okay, gotcha.
I just listening to us have this conversation, physiology, biology, complex stuff, but the processes that we've grown to use to manage care has to narrow that variability, and our ability to predict is really the gap that I think we're struggling with right now.
So one of the questions I had, because we've talked about kind of the team approach to care, and we know that providers are arrogant. They, for all of us, and not always want to follow cookbooks and things. There's always excuses for not wanting to. But one of the big challenges as well is that it's hard to play nice with one another sometimes. So how did you at MD Anderson kind of broach the issue of instead of working in our silos, we really need to branch out as work as a team? And what worked for you guys, and what do you recommend for others to do?
Well, as Saul had said, we still have ways to go. Yeah. It's been a journey. Like I've said, we have about 17 programs for enhanced recovery, 17 teams. Not all teams are the same. Each team struggles with different aspects of bringing all the players and the personalities together. But what worked for us is for each of the programs, we created an anesthesiology and a surgeon co-lead. And we let that team bring in other people, other clinicians who lay hands on the patient in their journey and let them develop their teams and gave them what are the goals of the team. And we help them develop a charter, give them the basic templates of the program, patient education material, the pathways which were successful in earlier teams, and let them adopt to that procedure-specific, patient-centric care. And let the team come up with their own elements and what works well for them. And the other thing we've learned is just because we've developed a pathway, that's not end-all. As all of us have learned, it's a continuous quality improvement. We have to optimize based on the results, the challenges, the outcomes we have to make it sustainable in the long term.
So we're using the Slido technology here, which allows online submission of questions, whether that be from the audience in front of us or our audience within the ASA in the broadest sense or around the world who are listening. And we have one question here that you sort of touched on already. It says, where does an anesthesia group start with ERAS? So before you answer that, go to Slido, slido.com, and the code to put in is TMTASA18. So that's slido.com, TMTASA18, so that's Top Med Talk ASA 18. And the question that's been voted up to the top is, how does an anesthesia group start with ERAS? Now, I think you referred to that, Vijay. It's finding those champions at the beginning, is it? Is that what you were referring to?
Absolutely. It's not only finding champions within the anesthesia community in that particular practice, but also finding a partner you can effectively work within the surgical service. It's very important that we have that engagement, that commitment, that relationship, that partnership, and then build with this dyad moving forward, bringing in other clinicians, but also having the leadership support this initiative.
Because the mantra in the UK perspective was very much the surgeon's got to want it. You can't make it happen. You can't bulldozer over a surgeon who doesn't want it to happen. Team anesthesia are crucial next members and champions. The nurses are right in there at the beginning because they do a lot of the hard yards. And usually you need someone from administration in there who therefore gets the support of whatever you call your thing locally, the C-suite or the... Is that how it panned out at Jukesol?
Yeah, I think it is exactly as you put it. I would, certainly add all the players in the medical profession, all be they physicians of multidisciplines, nursing, managers of care and wards. But the C-suite, if you will, the administration and the finance and the IT experts in your institution all have to be a part of that team, because if they're not, you will struggle.
Yeah, absolutely.
Yep.
Well, we have some other Slido questions coming in.
So here's a very practical one, because one of the big changes in enhanced recovery is this idea of the fact you get the tubes, the drips, the drains out immediately post-operatively, which as providers makes us feel pretty insecure, not to be able to see the belly drain and the... But this one's particularly about the Foley, getting the Foley catheter out immediately after surgery. Is that dangerous, and don't you get more acute kidney injury if you're not measuring urine output?
That's a great question. Actually, we've started a program within our enhanced recovery after thoracic surgery. All our patients get their Foley out after a bladder scan the next morning, whether they have an epidural or not. So the incidence of our patients getting thoracic epidural for post-operative pain management has remarkably diminished or decreased. But even in the instances when our patients have a thoracic epidural, particularly in thoracic surgery, when it's not obviously pelvic surgery, we are able to take away the Foley the next morning, and we've been monitoring our UTI rate, and there's been no change at all.
And the bladder scans really, that's what happens on our unit now for thoracic patients. It's really easy to do, isn't it? It's the point, your patients might be able to do it themselves at some stage, but it really is that easy, isn't it? If you're going to start anywhere with ultrasound, finding a bladder or not isn't that as easy as it gets. So I think Duke published something on the implementation of enhanced recovery and acute kidney injury. We went over it with Tim Miller last year, that I think you tracked your AK rates very, very carefully. And although you were getting the Foleys out early and you were stopping the IVs early and that sort of thing, there was, from looking at your large data sets, there was no hint of an increase in AKS. So there's no signal of danger there.
We are in the same, we concur with the evidence that Vijaya shared with us.
Yeah.
Great stuff.
All right, so that concludes our session here, our first lunch session for Top Med Talk here at the Smiths Medical booth 1519. Please, do we have one more question, Monty?
Just because Vijay's here.
Okay, all right, one more question.
Because I think we both work on thoracic units as part of our jobs, and Sol's a cardiothoracic anaesthetist. And this question is specifically about ERAS for VATS, which, yes?
Yes.
Yeah, and VATS is...
video-assisted thoracoscopic surgery.
Yeah, so he's got a huge amount to offer in thoracic surgery in general, hasn't it? Lung surgery patients, there's a lot. The principles have always been there, but applying them with a badge of enhanced recovery makes a big difference. Sorry to bomb that in. I just thought we had a great cluster of people to answer that question. Anyone disagree?
No, I strongly concur. Violently agree.
Violently agree. All right, so we are going to conclude our first lunch session here. Thank you guys so much for listening. There at home, if you are, please be sure, again, to subscribe and actually just vote into Slido. Come into Slido, ask questions, vote them up or down, take our poll, and please join us through social media as well, Twitter, Facebook, and LinkedIn for updates throughout the day. Monty?
I was just remind people that subscribing right at the moment is really important. We've generated about 300 podcasts now. They're all free and open source, but at some stage we're going to have to get those organised, and that means that some of it will probably have to go behind a paywall to facilitate a fancier application. But for everyone at the moment, it's completely free. You can get access to the whole back catalogue. So if you subscribe now, not only do you get all of that for free, you also get a regular newsletter and notifications of the latest podcast, and there's quite a variety. So we had Henrik Kellett live this morning, and we're actually running an Extreme Everest Hypoxia series at the moment as well. We're kind of all over the place from the point of view of interesting topics, not only talking to these wonderful people here. And remember, it is the broadcasting arm of evidence-based perioperative medicine.
And we actually have a booth.
We do have a booth here at the ASA, and in particular, EdPom USA. Sol, EdPom USA very quickly started when?
2 years ago, running strong and solid. We are about to have our third meeting, March 22nd through the 24th in Dallas. Baylor is going to be our host site. And we're extremely pleased with the pace and tone of how that's picking up traction very rapidly in the United States. So
And that does big picture perioperative medicine. It does a practicum about how to set up clinics. It does enhanced recovery 1.0 to 3.0. It's a little bit...
Focus is... So there's a gap of knowledge, for sure. We still have a mission to teach people why they should do what we're trying to teach them they should do, for sure. But we also recognize that there's a fundamental disconnection, however inspired one may be when they go to a lecture or hear a Top Med Talk podcast. They go home and they look at themselves in the mirror and they're all ready to do what they just learned and realize they have no idea how to begin. And so a significant focus of the APOM USA Master's course in perioperative care is to teach people how to do things, how to stand up these programs, how to be able to get started and work toward implementation, a very nuts and bolts approach to it.
And we'll be sitting down with you later, Sol, to reflect on 20 years of EdPOM and exactly what EdPOM USA has to offer, so we look forward to that.
Looking forward.
Yeah. Well, thank you guys so much to our special guests, Sol Aronson from Duke, Vijaya, Gottumukkala from MD Anderson. I really appreciate it. Hopefully we're going to be having more conversations like this going forward and hopefully just a couple years talking about the wonderful success throughout the U.S.
Thank you.
for
it's a pleasure.
recovery. So
We'll be
much.
back in 5 minutes.
We are going to be back in 5 minutes.
With a wonderful new guest.
That is. Wonderful new guest. Check it out. Carol Peden will be with us in just a moment.
Top Med Talk.